All right, let's talk about malignant melanoma. It's dermatology. It's lecture number 6. It's actually week 6. You just told me you're going to do the midterm on week 7, so this will work for week 6 lecture. It's winter 2021. Here we go. Malignant melanoma. Malignant melanoma. There it is right there. One of the looks of it. It has several different looks, several different types of it. And watch out for that red little rim, little inflammatory rim around a really black, ugly raised lesion is really, really bad. That needs to be seen by a dermatologist ASAP. But there it is. So some A.K.A.S, oftentimes it's just called melanoma. Erroneously, it shouldn't be called superficial spreading melanoma, even though it is, because this is one of the categories. SSM, lentigo malignant melanoma, that's a different, we talked about that last time, but those are some A.K.A.S, but I'm going to call it either melanoma or malignant melanoma. And it is a mutation of the melanocytes, which live down in the stratum basale. We've talked about those quite a bit. Those are those cute little octopus-looking cells that inject the newly born keratinocytes with melanin, and the melanin guards the nucleus to prevent UV damage, and it's a good thing. But we said the melanocytes sometimes, well, they never inject themselves with melanin. So that's one of the great biological ironies, is melanocytes don't have any melanin in them, and therefore they are susceptible to UV damage. They are deep within the very first layer, right? Stratum basale, they live right there. So, but like any cancer, they get some type of mutation in them, and they become immortal and don't die when they're supposed to. And then they start dividing by mitosis. These immortal cells start copying themselves, and that's the definition of cancer. And eventually they break loose from their basement membrane and get into the dermis. And well, these are already in the dermis, right? They're immediately into the dermis, so that makes them a cancer. Remember, we talked about lentigo maligna, where they haven't made it into the dermis yet. It's a pre-form of cancer. Anyway, this one is the most deadly type of cancer of all the skin cancers. And it's not horribly destructive like basal cell carcinoma, just rips the tissue to pieces. But it metastasizes. For whatever reason, it just loves to zero in on the microcirculation and jump into the capillaries or the lymph capillary and get to other places in the body. The brain, the heart can even be hit by this, get into the bone, the lung, the liver, you name it, it can be anywhere. Where does it occur? It's seen on the skin. It can be in the mucous membranes, so sometimes it's very difficult to see. It can be in the eye, can be in the leptomeninges. What's the leptomeninges? That's collectively the pia mater and the arachnoid mater. So that's one word for those. Some types of it, we'll look at the types in a second, but some types are more aggressive than others. The most common type has a very slow radial growth phase. Remember we talked about that? If this is let's say that's the stratum basale, and there's the stratum corneum. This is the outside world. There's the sun up there. And then this is the dermis down here. The most common type hangs out right in here, and it spreads kind of radially or longitudinally to the stratum basale. So, and it can, as we'll see, it can give you some time at least to get to the dermatologist. The nodular form is very, very aggressive. And cells are going up too, right? Because you can see this on the surface of your skin. So you have cells going up as well in my little diagram here. But like the nodular type, boy, this one just goes straight down. Goes up as well, but remember, these cells are immortal, so they don't die, and it jumps in right in blood vessels. So that's the vertical growth phase. Horizontal growth phase is kind of horizontal to the stratum basale. So the most common type, which is superficial spreading, has a very slow radial or horizontal growth phase. Whereas the nodular type is very dangerous because it gives you no warning. Geez, if you're make an appointment at Stanford takes about 6 months to get in to see a dermatologist. It'd already be metastasized by that time in some cases. That's definitely a problem with this California healthcare system. It's completely overloaded. Right? The population has exploded. Although we are losing, people are leaving this crazy state. But still, there's way too many people and not enough medical facilities. They're building, Stanford has built some huge, just humongous new buildings and hospitals to try to handle all these extra people. But anyway, I'm digressing. So that's the story there. There are 3 gene mutations. I'm not going to get into the weeds on these mutations, but there are mutations in the nucleus of melanocytes, specifically in the chromosomes. And we have the BRAF mutation, the NRAS mutation, and the KIT mutation are 3 well-known mutations. Increase your chance of getting melanoma. Of all the cancers in men, it's the 5th most common type of cancer. It's the 6th most common type of cancer in females. I'm going to keep saying this because I know this is a very high-yield question. Boards and standardized exams, they always want to know who's the number 1 type of skin cancer. It is not malignant melanoma. It's actually basal cell carcinoma, which we have talked about. Number 2 is squamous cell carcinoma. The lifetime risk is about 1.5%. It is on the rise. For example, in the 1930s, it was only 0.07%, although it makes you wonder, how good their statistics was way back then, keeping track of things like this. But it is definitely on the rise. There's many authors and papers that I've read. It's on the rise faster than any other type of cancer, and they are concerned about it. They don't know what the deal is. Some of the theories, of course, are a thinning ozone. So it's possible. It's not been proven, but there's something going on, and we're not sure what it is. Maybe it's some new virus or some new pollutant in the air. We don't know, but it is on the rise. And in fact, it's predicted to double in the next 15 years, which is, that's really on the rise. If you're a white person, this is a white man. Great movie, by the way, White Men Can't Jump. You have a 10-fold risk compared to other races. So whites, and why is that? Because white people don't have melanin in their skin as much. People of color have more melanin. The darker you are, the more protected you are from skin cancer. People in the Sun Belt, Australia, New Zealand, have the highest numbers of malignant melanoma because they're closer to the equator, and that's a very outdoorsy place. Median age of diagnosis is about 57, and the median age of death is 10 years later, 67. Accounts for 90% of all skin cancer deaths. So if you're going to die of a skin cancer, this is most likely the one that it'll be. It's also the most common type of cancer in young adults, especially females. Basal cell carcinoma, again, is still the number 1. Some risk factors. So if you have a personal history or family history, mom and dad have it, or you've had it before, you're at risk. People with red hair, blue or green eyes are at risk. They're very lightly melanated, so they tend to be susceptible to UV damage and mutations. The tendency to burn, if you can go out and get a nice tan, you're less likely to get cancer than those people who try to go out and get a suntan and they just get red. A condition called xeroderma pigmentosa is a genetic disorder that also decreases the repair mechanisms of DNA mutations. Those people are at risk. History of intense intermittent sun exposure. So, in other words, sunburns. So the amount of sunburns you have is directly related to your chances of getting cancer. Also, chronic total sun exposure is a risk. tanning bed exposure. Tanning beds are no good either. You need to stay out of those things no matter what the advertisements say. They're not good. Any type of UV radiation, no matter A or B or whatever, it's not good for you. And having a lot of moles on your body, the moles are called, we'll learn about those, but melanocytic nevi, or having a lot of lentigo lesions, or lentiginous is a A.K.A. for multiple patches or multiple lentigo lesions, you call that lentiginous. Those are also risk factors. And then we have this girl who has supposedly 250 moles or more than 250 moles on her body. So she's definitely at risk for melanoma in the future. Strongest risk factor is having a combination of bad genetics. Mom or dad had melanoma, and then you are a sunbather. You've been burned a million times when you're a kid. You're at risk. Now, these are the ABCs. These go for all skin cancers, not just malignant melanoma. Guarantee you, you're going to get a question on this, even on boards, because primary healthcare provider, what's your job? Your job is to see if the lesion, skin lesion, breaks one of these rules, and if it does, you need to send them to the dermatologist, or you will get sued if it does turn out to be cancer and you miss it. So ABCDE, so A is for asymmetrical shape, very difficult to fold it in half. Usually goes with a border irregularity. These two are very commonly connected. So a really kind of a rat bitten where the border is chewed up and irregular looking. Variegation is very important. We've talked about how important that is. The lesions that have multiple colors, especially if it's strongly variegated, where it has some black in it and has some light in it or gray in it, that's a risk. Diameter bigger than a number 2 pencil, so anything bigger than about 5 millimeters is the number 2 pencil eraser size. And one of the most important ones is whether or not it's evolving. Is it getting bigger? And the patients are really the best people to keep an eye on that. And you should always listen to them. If they say it's getting bigger, you need to get a biopsy of that thing and see what's going on. And there's a lot of imitators. Melanocytic nevi, seborrheic keratosis can mimic a lot of these ABCDEs here. There are 4 malignant types of melanoma, or 4 types of malignant melanoma. They're all malignant. So you definitely need to know these. So superficial spreading is the most common. We'll look at that specifically. Lentigo malignant melanoma, we've talked about that last week. We'll talk just a tiny bit about it again here. But that's basically melanoma of the head or neck. And sometimes the histologist or the pathologist who checks the biopsy is the only one who could make the difference. The arcuate lentiginous melanoma, this is the one that killed Bob Marley. So this is the one that can be on the palms, the glabrous skin, right? The palms or the soles of the feet, or under the nails. That's the one that got Bob Marley. We'll look at that quickly as well. And then nodular melanoma is the last type. This one is very, very aggressive and deadly. This is the one where if you're trying to get into a big center like Stanford, you're going to be in trouble because it takes so long. These can spread within months. Superficial spreading, okay, we'll look at specifically these types. There's a picture of it there. It's usually more flat and not nodular, but this is typically diagnosed at the age of 50. This is by far the most common of all the malignant melanomas. Now, these superficial spreading usually have a very long radial growth phase or a horizontal growth phase. So they're in the dermis, so it takes time to get into the dermis. Now, it takes time to dive down into the dermis. I'll change that on your slides, but it takes time. It's cancer has to be in the dermis. It has to be in the dermis in order to be cancer. But it takes time to go into the subcutaneous tissue. And this radial growth phase can go from 8 months to 24 months. So it can go very, very slowly. We can see it anywhere, but it's usually on the trunk of a man, like on his back, sun-exposed regions, or on the legs of a female. It can start de novo. What does that mean, de novo? Can start brand new out of the blue, or it could start not de novo from a pre-existing condition like a mole. About 50% of them actually come from a mole. A mole can turn cancerous. And the trouble was, it wasn't really a mole. It just looked like a mole. It was melanoma all the time, because in the early phase, they can look just like a mole. Early on, it's cancer in situ. That means it's in the horizontal phase, and it's not digging way down into the depths of the dermis or even into the hypodermis layer. And yeah, and so the treatment of these is very successful if they haven't gotten deep into the dermis or subcutaneous tissue. That's a good thing. They are typically, what do these superficial spreading melanoma look like? So this is a dermoscopic view, so you wouldn't be able to see this. This is a little magnifying glass that the dermatologist uses, but you can see the different shades of brown. It's variegated, has irregular borders, which are kind of notched, has areas where there's almost, where it's reabsorbed almost. It's almost back to normal here. That's classic with these things as well. That's a superficial spreading one. Let's go real quick here. Let's look at this one. So here's another one, superficial spreading. They're usually flat. They don't have nodules. If they have nodules, then there's a nodular type of malignant melanoma. This is superficial spreading, and that word comes from because it spreads kind of horizontally or superficially. It doesn't like to dive in until later. But you can see this one is the borders are really notched out, and it's densely variegated. It's almost black here, and it's almost back to skin color here. Can't fold it in half. It breaks all kinds of ABCs. I mean, that one's way over 5 millimeters. So that's kind of the story there with that. So it doesn't last forever. So after a reasonably long radial growth phase, suddenly the rate of mitosis of these mutated cells greatly increases, and it starts going downward into the deep part of the epidermis and even gets into the subcutaneous tissue. This is not good, and it's, for whatever reason about all types of malignant melanoma, it's almost like it knows how to get into the capillaries or the regular or the lymph capillaries. So it seeks out, I don't know if it seeks out, it's not intelligent, doesn't have a brain, but it's not put off by the tunica adventitia of these vessels. So it can go right through the tunica adventitia and get into the blood or into the lymph system. And that's the problem with this thing. And yeah, they can become more papular or even nodular in the later phases, which makes it difficult to tell apart from a nodular. So here is a malignant melanoma here, and you can see we have a nice nodule that's formed. It was a superficial spreading type, and the patient waited too long. He goes, "Oh, look, see, it's going away. It's going away. I don't need to see the dermatologist." And then saw finally this papule popped up. He goes, "Oh, I better go see the dermatologist," but it's too late. It's already metastasized at this point. Bad sign when it gets a nodule like that on it. 60% of the tumors, and this is the problem with it, it can fool people because 66% of the tumors will have at least have part of the tumor that has gotten better, and the patient thinks, "Oh, it's getting better." It won't be the whole tumor though. That the whole thing doesn't regress. Just little patches will turn skin color or gray. If it turns gray, that means that the pigmentation, the skin is on its way to turning normal again, and that's not good. Here's another malignant melanoma, and you can see the big patches in here. It's a dermatopic scope view again. But again, look at the notched borders. It's flat, superficial spreading melanoma. Will it ever completely disappear? It's incredibly rare for it to completely disappear. There's always an exception to every rule, but it usually doesn't. Okay, but because the tumors do get kind of patchy looking. I mean, it is regressing here. It's not regressing here, but because it does have areas of regression, it's an argument that there might be some immunologic component to this as well. I'm not going to go down that rabbit hole, though. So now we come to nodule. This is a really, really bad one. So this doesn't look anything like the superficial spreading we just looked at. It's a raised kind of ball-looking lesion. It's a nodule. We've talked about the language of dermatology. It's a nodule, and this one is no joke. This one doesn't monkey around. It's spreading superficially or horizontally. This one dives straight down. It's the most aggressive of the 4 types. Typically shows up in the 50s. And counts for 22% of all melanomas are these horrible bad ones. So that ain't good. Frequently seen on the trunk or on the scalp or on the neck. And there's a big nodule right there. And that's the sign of these things. They're nodule looking. Okay, they do not have a slow radial growth phase. In fact, they have hardly any radial growth phase. They have a vertical growth phase that's very, very quick, and within months it can be down into the subcutaneous tissue and into the bloodstream. Very dangerous. They're usually black nodules, so they're not flat. They're usually bumps. They may sometimes be pink or red. So here's from dermnetnewzealand.org, great website. Here is an example of a red colored one. They can ulcerate and they can bleed, making them tough to tell apart from basal cell carcinoma. Likes to do that. Have we talked about it? I don't think we have. We will talk about it if we haven't. So these are believed to develop de novo. So these don't come from a mole usually. They're flat. They just pop out of the blue, and they grow and they grow and they grow very quickly. And again, the prognosis is not good with these things. You have to catch these incredibly fast. Now we did talk about lentigo malignant melanoma. This is a form of melanoma that comes from lentigo or lentiginous. Lentigo lesions or multiple lentigo lesions is lentiginous. And remember, there's a lentigo malignant, which is the precancerous phase, and then it can shift into full-blown lentigo malignant. Now this one does have, remember from last week, a very slow, super slow radial growth phase. Much slower even than superficial spreading type. So if you have to have one, this is the one you want to get. It's seen in about 10% of patients with malignant melanoma. It's almost always on the face, this one. This one hits people in the same age, 50s, 60s. But this is also one that shows up in younger people as well, which is a little unusual. So in the 20s is another kind of target age of this one. And slow growing, we said, is a macular patch, so it's usually fairly flat. It's variegated, black to brown. And the key is it often contains a nodule within it. And that's how you can separate it from lentigo maligna or lentigo, because those don't have nodules in it. But sometimes it's hard to tell apart from nodular melanoma because nodular melanoma has nodules. The difference is nodule melanoma has just a nodule. This one has kind of a flat patch type and then a nodule within it. And so that's kind of the difference between these. They can sometimes progress, as we said, from lentigo malignant about 5% of the time. And here's one. It's kind of hard to see, but there's a nodule right here. Another nodule poking up right here. And it's very dark right here, and it's very light over here. These are usually, because they spread superficially and their horizontal growth phase is so long, these things get massive. They get really, really big. Much bigger than superficial spreading melanoma usually. And same with the nodular melanoma. These things take a long time, so they spread way, way out. All right, let's look at Acral lentiginous melanoma. So here's my pronunciation guide. Like from Acral lentig, like big, tig, enus. Acral lentiginous melanoma. This is relatively uncommon. It's about 5% of all melanomas. Typically shows up in the 60s. Now, to be one of this ALM, you could call it if you want, it can only show up on the hirsute or the glabrous skin. Remember what glabrous skin is? That's the soles of your feet and your palms. That's where there's no hair. That's glabrous thick. It's got an extra layer. Right, we learned that. And or could show up anywhere in the nail apparatus, usually underneath the nail. And if it's in the nail, then it's actually called subungual melanoma. So people of color are much more at risk for this type. 70% of the people diagnosed with ALM are African Americans. So just like superficial spreading melanoma is more of a white person's disease, this is more of a people of color type disease, namely African Americans. And how do these ones present? Well, black to brown macule with variegation in it. The borders will be irregular, so it can be misdiagnosed very oftentimes. 33% misdiagnosis rate if it's in the nail apparatus. How come? It looks exactly like something called longitudinal melanonychia. And we will have a whole lecture, or at least a half a lecture, on longitudinal melanonychia. Those are the little streaks that some people get in their nails, especially people of color, especially African Americans get these longitudinal streaks, and they're completely harmless. They could be just a form of a nevi causing that, and we'll look at those, but they can be sneaky. This is what killed Bob Marley. Hutchinson's sign is the dead giveaway, so if it gets starts going into the fingers, the skin of the fingers around the nail, that's a really bad sign. That's Bob Marley. This is really, really bad, so this is subungual melanoma. And just like any melanoma, it loves to get into the bloodstream and get into the lungs and the liver, and can get up in the brain, so it causes all sorts of trouble. But you can see not only is in the nail, it's in the skin around the nail as well. So this is really bad. It's metastasized already at this point. Okay, here's another really bad one. They came in way too late, right? It's already gotten way up here into that interphalangeal joint. Yep, no good. We'll talk about that specifically when the time comes. There's another, that's a nodular melanoma, right? It's nodule. It's just like a big bump sticking out of the skin, and it's black. It's not superficial spreading for sure. It's not lentigo malignant melanoma. Those are all more patches, which may or may not have nodules within them. When it's just a flat out ugly looking nodule, it's nodular melanoma. Those are very, very dangerous. So this one, what do you think of this one? So there's the ear right there. So this is flat, so it can't be a nodular melanoma. This is actually a superficial spreading melanoma. It's very notched and dug out. It's got these huge kind of areas of semi-normal skin there. It's very darkly variegated. And so that superficial spreading melanoma. What about this one? 7 millimeters, so it breaks the ABCs. It's variegated, right? Maybe even a little bump right there. It's not densely variegated. It's not black here and gray here and light brown here. And it really, honestly, except for this bump, it looks fairly innocent, but it still breaks the ABCs. It looks like seborrheic keratosis, the great imitator. It actually surprisingly turned out to be malignant melanoma on biopsy. So, and it's the only giveaway was this nodule that grew right there. But that's why for primary healthcare providers like chiropractors or medical students or PT students, you just look for these. If it breaks the ABCs, you send it out, you refer it out. So yeah, you got to catch these things early, right? That's the key to survival. You need to have a dermatologist take her giant magnifying glass, or sometimes they're glass like attachments. They look like microscopes on your glasses. They need to be looked at by a dermoscope. which you can see, and that has a more characteristic look. The patient history is very important too. Has it changed shape? Has it changed color? Those are very important clues. If it's growing in size or it got really dark and doing crazy things, it's probably cancerous. These are the most sensitive clinical findings for melanoma, according to Bolognia. Some other signs of melanoma: erythema from inflammation. Right in the opening picture, we looked at one of those, a black ugly nodule, and it had a little ring of redness around it. That's a really bad sign that it's malignant melanoma. There's the EFG rule, in addition to the ABC rule. If it's elevated, that was part of the ABCDE rule, but you could add an F in there. Is it firm? Most cancers are really hard and rock-like. Is it growing? That's probably the most important one of all. The accuracy of diagnosis is not the greatest. Even by a trained dermatologist, it doesn't exceed about 75%. However, when she gets that giant magnifying glass, that dermoscope, it brings the accuracy up to 90%. And I mean, you guys don't know how to use one of those. So that's why you got to make the referral. And even, so that's 10% of melanomas can be missed even with the dermoscope looking at it. So there are things called featureless melanomas that are, they can just fake even dermatologists out. Garbe's rule of dermatology. I've asked that question before. So Garbe is a famous dermatologist. He says that if a patient comes into your office and is worried, don't take that lightly. You should be a low threshold for, I should just read it, right? If a patient is worried about a single skin lesion, don't ignore it. Don't ignore their suspicion, and have a low threshold for performing biopsy. Right? So don't be scared to biopsy these things. Differential diagnosis, there's a bunch of conditions that can look like malignant melanoma. In fact, you can break them up into two categories: melanocytic and non-melanocytic. So let's take a look at the melanocytic imitators. Well, these melanocytes, these are nevi, these are moles. So these are moles that can turn into mainly the nodular form of malignant melanoma. So it's the Acral nevi, the Clark's nevi, atypical and typical Spitz nevi, congenital nevi, and we'll talk about congenital nevi more. But these all can look just like melanoma. And then the non-melanocytic nevi, these are the ones that we know about. Some of these already. We talked about seborrheic keratosis, the great imitator. Actinic keratosis we talked about, pre-squamous cell cancer. Lentiginous, we've talked about them. We will talk about basal cell carcinoma if I haven't already. There's a superficial, a pigmented basal cell carcinoma that can be difficult to tell apart. And there's a thrombosed hemangioma, which can look awful like cancer. We're not going to talk about that. What's the prognosis? Again, early recognition is the key to saving lives. It's got to be caught while it's still in that radial growth phase and hasn't gotten way down deep into the dermis, or even worse, into the subcutaneous tissue. Because once it gets into the deep dermis and subcutaneous tissue, it's aggressive, and the odds are it's already gotten into the lymph system or the bloodstream itself. Let's look at another one. Well, that one's really crazily variegated, right? It's black here, it's brown here, it's light brown here, it's gray. That means it's resolving right there, heading back to normal. That's classic superficial spreading malignant melanoma. What about melanoma versus a nevus or versus a mole? So typically melanomas have more of the following characteristics compared to a nevi. So melanomas are more densely variegated. Moles may not be variegated at all. Melanomas have very notched out irregular borders. Moles are more smooth. Melanomas grow. Moles can grow, but then they stop and they just sit there for the rest of your life. But melanomas get bigger and bigger and bigger. Melanomas tend to be nodules, and well, nevus can be nodules too, but not really. They just can be raised, not really a big ugly nodule. That said, in the early stages, melanoma can look exactly like nevi. Biopsy, you can see, unfortunately, you have to take really wide margins. Now this is, her stitch is ripped out because the if you ever watch the pimple popper, how she's almost like a plastic surgeon, she's meticulous about fixing these so it doesn't look that bad, but sometimes scar tissue grows in here, and maybe the dermatologist wasn't such a good surgeon. She should have maybe went to a plastic surgeon to do this. But yeah, you have to take a wide biopsy. You have to get the sentinel node lymph biopsy as well to make sure. We talked about sentinel nodes, the supraclavicular nodes. Make sure it hasn't gotten loose. Surgical excision has to be done with wide margins if it is cancerous. What do you think of this one? Well, it's very black here. This is raised looking. This doesn't look good, does it? Don't know how big it is. Probably 5 millimeters or so, but it's densely variegated. The raised is not. It's not a good thing. This is actually a turned out to strangely be a superficial spreading melanoma, which has entered the radial growth phase. But it's very hard to tell this apart from a nodular malignant melanoma. If it was on the face, it could have even looked like lentigo malignant melanoma. Sometimes you just can't tell. What about this one? Wife says it's been on the patient's back for about 2 years. But it seems to be going away, so they never bother to come in. That's always a bad sign, right? It's got that big ugly nodule. I mean, this has to be looked at by a dermatologist. It turned out to be a superficial spreading melanoma that has shifted into the growth phase in this area right here, and that's why the nodule has popped up, because it's in the vertical growth phase. Yep. How about this one? Now this one doesn't look that bad, right? It's probably 5-6, so it says it's 6 millimeters. It's been there on the form for the last 3 years. It stopped growing. That doesn't looks like seborrheic keratosis. It could be, and that's exactly what it is. And yeah, that's not that bad. If it breaks the ABC rules, to protect that expensive license that you're going to school for, you should refer out. This is not a good sign though, right? If you don't have moles on your palms or on the plantar surface of your feet, and this looks like popped up on the patient's plantar surface. Looks like the heel right here. No good. It's variegated, light brown, dark brown, huge notch taken out of it. That's not good. That's an arcual lentiginous melanoma that turned out to be. All right, so that's enough on malignant melanoma. We'll see you next week. Actually, you have a test. It'll be week 7 will be next week, so your midterm sounds like it's going to be on week 7. See you later.